we will moving towards the last session of today's scientific affairs, and it is giving me immense pleasure to invite today's showstopper, Dr. Bismay Kumar, nephro consultant and transplant physician, clinical lead and head of nephrology, Narayana Super Specialty Hospital, Howrah, to speak on the topic role of N-Acetyl Cysteine and Taurine in reducing microalbumin and creatinine level. And to chair this particular session, I'd like to invite Dr. Mridul Bera, one of the founder member and torch bearer of Howrah Diabetic Society.
So, it's the last session of today. So, without much ado, I'm just giving the Dr. Bismay Kumar the mics. And the topic is the role of N-Acetyl Cysteine and Taurine in reducing the microalbuminuria and the creatinine, the evidence-based case studies.
Yeah, so I started the day and I'm ending the day. So I'm the last batsman and we are completing the day with my presentation. If you believe in Hindu mythology, do you know that there are 4 dhams? You know that? Dwarka, Badrinath, Jagannath Puri and Rameshwaram. So every Hindu at the end of his life has to attend this 4 dham if he is practicing his religion. Similarly, for uncontrolled diabetes also there are 4 dham. A cardiologist, a retinologist, a neurologist and a nephrologist. They have to visit us before they go to heavenly heaven. And that is the reality. So probably if you see, there are also 4 dham of drugs. The MRAs, the SGLT2 inhibitors, the ACE, ARB, and probably we have the GLP now coming up. But there are many more to that. Still patients go into end-stage renal disease. Do we have anything to save them? Can we prevent them from going on end-stage renal disease? Yes, probably we have some answers in this drug. So today we are going to discuss N-Acetyl Cysteine and understand does it has any role in diabetic and hypertensive patients. Well, these are my disclosure. This is basically So Forts India has supported this program. I have participated in this study as a principal investigator, and my clinic was a part of this study. Well, in chronic kidney disease, it's a progressive disease. You go from stage 1 to stage 5, you keep on losing a nephron, and you end up in end-stage renal disease, and that's a reality. But do you see this graph? And you have gone through this slide in many presentations the whole day. The main problem with this is that red zone, the heat zones. And if you try to control this patient, you have to control the urine ACR. So do we have many drugs for that? Whatever drugs are there, still we have patients going into end-stage renal disease. The causes of CKD. Diabetes is the major cause of chronic kidney disease, 31.2%, but there are other causes of CKD like you have hypertension, you have ADPKD, you have renovascular disease, and there's a big group called undetermined. I would rather say they are the unfortunate because they miss the diagnosis early, they end up with end-stage renal disease, and we really don't know what is the cause for chronic kidney disease in such patients. So diabetes and hypertension by far is the major cause of microproteinuria, which is the main problem for chronic kidney disease progression, and it is the main marker of cardiovascular mortality. We all know about it. Now, what is happening in chronic kidney disease? There are 3 major things which is happening. Metabolic disturbances, hemodynamic factors, mediators, and there are inflammation and fibrosis. Metabolic factor, through reactive oxygen species, we have the advanced glycation end products, which leads to this inflammation, and that inflammation ultimately leads into fibrosis. Then we have the hemodynamic mediators. All the drugs which we have are working on that. The angiotensin II enzymes are increased, aldosterone and endothelin levels are increased. That causes fibrosis. Lastly, there's inflammation and fibrosis. So we have drugs to mediate through hemodynamic factor, probably something to control sugar, but do we have anything to counter the reactive oxygen species or the inflammatory process and mediator? Probably we will have these answers in the coming slide. So ultimately these 3 important things, metabolic disturbances, hemodynamic mediators and inflammatory process, they all ultimately end up in tubulointerstitial damage and chronic kidney disease. So here is N-Acetyl Cysteine in kidney. It is basically a direct scavenger of the free radical. It's an antioxidant which has been reported to protect the kidney from injury induced by, we use it in contrast media related injury, in contrast it induced nephropathy, ischemias, and toxins, we do use it. NAC has been reported to decrease creatinine. It has been reported. We need more studies. Levels in subjects with normal kidney function. NAC is dramatically reduces the albuminuria, and in many systemic analysis, meta-analysis, there were 15 trials which was associated with NAC, which showed improved kidney function, relieved inflammation, and reduced cardiovascular events. So this was a one trial, which was the biggest trial. It was a Taiwanese trial, included 125,000 CKD patients, which was followed for 10 years, and they were associated with 18% reduction in the risk to go for end-stage renal disease. This was a recent article which showed that NAC, that is N-Acetyl Cysteine, could be used to reduce CKD in progression to end-stage renal disease. This was a 3-year retrospective study. The incidence rates of hemodialysis was significantly reduced in this study versus the non-NAC users. Then that's the only story. NAC? No, there's another molecule to add on the NAC. That is a taurine. Does it have some effect? Yes, it has postulated to have some effect. It increases the renal blood flow. It influences the renal vascular blood flow. It increases the serum level of nitric oxide. It reduces the RAS. It blunts the elevation of cytokine, and taurine depletion showed high blood pressure, and reduced urine protein excretion is seen by use of taurine. Possibly taurine in vasculature, it increases the vascular blood flow. In glomerulus, it causes scavenging of reactive oxygen species. In tubules, it improves the sodium transporter. It reduces the osmotic-related injury to the interstitium. That was also a study in this study where actually the mechanism has been reported how taurine works on the osmoregulatory mechanism in chronic kidney disease. So, ultimately, it is the imbalance between what? Between the antioxidants and reactive oxygen species that causes oxidative stress, and that leads to the tissue injury, inflammation, and apoptosis. Do we have a drug to counter this? Probably yes. We have taurine and N-Acetyl Cysteine to work on this mechanism. Now, this is a picture of a glomerular basement membrane. You can see there are small slits between the red marks. That is the podocytes, and there where the protein leakage occur. So reactive oxygen species works like this inflammation which damages the podocyte, and there is the protection by N-Acetyl Cysteine and taurine. So we have 3 studies to discuss in this presentation. One is a single center pilot study on type 2 diabetic patient. One was a study which I was a part of. It was a 6 nephrology center RCT. And lastly was a EMR based study of 9 diabetic renal study of real world evidence. Starting with the study 1, this was by my own boss. I worked with him, Dr. Vijay Vishwanathan in Chennai. This was the study I just joined, and that study got completed that year. 41 diabetic patients, 31 were given combination of taurine and N-Acetyl Cysteine, ACE-ARB treatment group, and 10 patients were only on ACE-ARB alone. Duration was 3 months. Short study, but yes, it showed good urine ACR reduction of 85 followed to 45 milligram per milligram creatinine. That was significant. Then came to our study. This was a very well-planned, prospective, multi-center, randomized, placebo-controlled study to evaluate the effectiveness of N-Acetyl Cysteine taurine in preventing progression of chronic kidney disease. 6 centers, one was my clinic, one was Gangaram Hospital, one was Safdarjung Hospital, one was Meenakshi Mission Hospital. You know, these are very famous hospitals in India. One was Grant Hospital, Mumbai, and one was BMRC Hospital, Barakpur. So we included patients between 18 to 65 age group, which was CKD1, CKD2, and CKD3. That means our cutoff GFR was 30. We took the GFR above 31. And the creatinine cutoff for our patient was more than 3. We didn't take advanced chronic kidney disease patients. Exclusion criteria was type 1 DM patients, severe advanced chronic kidney disease, history of myocardial infarction, CABG, PTCA, angioplasty, cerebrovascular events in the past, any cardiac failure in the past, and any untreated urinary tract infection, sick patients, acute on CKD, all these patients were excluded in our study. Now we grouped this patient in two groups. One group which had urine microalbuminuria less than 300 milligram per day, one above that. Now we saw that overall urine albumin creatinine ratio declined by 18.6% in the NAC-taurine group, and there was 34% reduction in the microalbuminuria group and 17.5% reduction in the macroalbuminuria group in the NAC-taurine group respectively. So that was a significant numbers which we gained. As we talk about the GFR chain, NAC-taurine group along with low protein, all these patients were put on low protein diet of 0.8 milligrams per kg per day, helped in the preservation of eGFR end of 6 months. 6 months was our study period. NAC-taurine group showed 1.32 ml greater increase in eGFR compared to placebo when we spoke about CKD stage 3. And in stage 1 and stage 2, there was 3.27 ml lower decline in eGFR compared to placebo. We also studied the cystatin C change from baseline to 180 days. We saw in our group that overall cystatin reduction was 21.89% in a NAC-taurine group compared to placebo. Its median change from baseline to study end between the two groups was also statistically significant. So to summarize this study, we had 18.6% overall reduction in urine albumin creatinine ratio seen in NAC-taurine group compared to placebo, and 34% reduction in microalbuminuria and 17.5% reduction in the macroalbuminuria group. In cystatin C group, we achieved a 21.89% reduction in the NAC-taurine group when we compared with placebo. And NAC-taurine group, along with low protein, helped in the preservation of eGFR at the end of 6 months, and that was our inference. Last, this was a study done in Chennai. It was a retrospective study. They took all the EMR data and tried to analyze what happened. It was a real-world, prospective, multi-center observational study. It was for 1 year, October 22 to October 23. The film-coated tablet of N-Acetyl Cysteine and Taurine with a low-protein diet was given to the patient. It was to evaluate the effectiveness of N-Acetyl Taurine on change in microproteins in diabetic and hypertensive patients diagnosed with CKD 1, 2, and 3 CKDs. Eligibility criteria, again, adult patient with diabetes or hypertension, which may be diagnosed with CKD stage 1, 2, 3, and adult patients with microproteinuria resulting from between 30 to 300 milligram per day. Exclusion criteria, all who incompleted the medical record were excluded. Now, 305 patients were captured in this study. The data extracted from the EMR, 9 participating investigation centers in Chennai, Kolkata, Mumbai, and Ahmedabad were included. This was the center of answer. One of my own batchmates, Nandita, was a part of it. His father's center, Ramchandra Diabetes Hospital, is in Chennai, very famous. I've been there. So what they found was a mean reduction in urine ACR of 11.77% was observed from baseline to day 90 in these patients. The urine ACR reduction was 16.7% in CKD 1, 14.4% in 2, and 5% in 3. And it was evident that the effect of N-Acetyl Cysteine in reducing urine ACR was more prominent when administered early in the stage of chronic kidney disease. For the patient with both diabetes and hypertension, the mean reduction in urine ACR was 11.16% for diabetic, and it was 15% for hypertensive patient. So to summarize this study, NAC-taurine was effective, significantly reducing urine ACR by 11.77% within 3 months in patients with early diabetes and or hypertensive CKD. And CKD 1, the reduction of urine ACR was 16%, 2 was 14%, and 3 was 5.1%. So in patients with diabetic CKD, definitely NAC-taurine significantly reduced the urine ACR, compositely around 15.9%. To my friends, to summarize, the standard treatment, what we have today, NAC-taurine can be considered as an adjuvant therapy. These are adjuvant therapies in patients with microprotein from CKD to 1 to 3. Significant reductions in microprotein in 3 to 6 months' time I have shown in these studies. So to start NAC and taurine early in CKD 1-3 stages with BID dosing can be considered, and NOC taurine benefits better in diabetic patient and microalbuminuria patient. Thank you very much, and happy pujas ahead. So, any questions?
Thank you, Vishwa. A small question, very silly question though. Any clinically relevant side effect of N-Acetyl Cysteine Taurine combination?
GI side effects can cause, first thing, it has a smell, so it can cause nausea, vomiting. Any patient has hypersensitive reaction, it can cause diarrhea, it can cause hypersensitivity reactions. And probably if you have patient, mostly you have GI side effect, which is more common with N-Acetyl. Otherwise, it's a very safe drug.
Another practical question. So you have said in this last slide that it has been the NAC and can be an useful agent, particularly in the diabetic and the CKD patients. So I think you have enough experience that in a diabetic population it acts better. And first question is that you have that experience, the diabetic patient fare better with the NAC. The second question is that just simple questions. In your study, the NAC you are using in the stage 1 to stage 3 CKD patient. But in practically what has been seeing, the NAC prescription has been there where the patient is having CKD stage 3, below the 3 beyond the stage 4. Because when you just say the nephroprotective drug, only two agents that is come to my mind. One is the SGLT2 inhibitors and another is the RAS blocker. So in the context of if the patient is having the CKD stage 1 or 3, it is more pertinent to use this SGLT2 inhibitor and the RAS blocker rather than using NAC. In your clinical practice, you are using more in the stage 1 to 3 patient or stage 4 and stage 5 after giving this RAS blocker and the SGLT2
See,
inhibitor?
as of the clinical practice is concerned, I use it till stage 3. Stage 4, stage 5, we go more with adjuvant therapy. We have the options of going for low protein diet and keto diets. Or we can also consider using pre-probiotic for these patients because that also works in CKD stage 4, stage 5. But stage 1 to stage 3, we have studies which are short-lived, 3 months, 6 months, maximum 1 year. If you have patients who will go from CKD 2 to 3 to 4, you need a study which is beyond 1 year. So if you have studies which is beyond 1 year, then we can actually use these drugs even at higher levels of lower levels of GFR. But we don't have that. Whatever study we have, it qualifies till CKD 1, 2, 3. So these drugs definitely don't have any big RCTs to support. Smaller studies are there. So it can be used as an add-on therapy, but it cannot be used as only therapy.
I'm just talking this because you have then agents that can potentially protect your kidney from, there will be the protection, reduction of the EGFR, protection of the EGFR or reduction of the UACR, improvement in the UACR. Now the thing is that we are often using this SGLT2 inhibitor quite a lot because up to EGFR of 20 we can use the SGLT2 inhibitor. And also we can use this definitely the RAS inhibitor. The only problem with the RAS inhibitor still I think for a nephroprotective agent you should use the RAS inhibitor in every CKD patients. Now the thing is that when you just use the RAS inhibitor there is a problem of hyperkalemia and there is the increase in the creatinine level. Now we are using a lot of the patient, we can use the drug that we can reduce the potassium level. The drug which is coming, that is sodium zirconate, so this is the Localma, which can be a good agent, particularly in this group of patients with the CKD with an hyperkalemia with the use of optimization of the RAS blocker. So in that scenario also, whether these drugs, which I am also using this drug, which can be an added or additive agent, additive factor on top of the SGLT2 inhibitor, RAS blocker, and the newer anti-hyperkalemic drugs. So what do you think? So we can have the better options of using all
Probably
these molecules.
time will answer this question, but as of now, what options we have these options. So still this drug is in pipeline. It has not reached Indian market. It is there in European market, but we are still know what will be the cost, how these patients can afford this medication, how long it will, what they will do to the GI tract. Can they use it for a long time? So all those are questions which we don't have any answers as of now. We don't have major studies in CKD population, so we have no idea about how it works. But yes, if you talk about the ACE-ARB and SGLT2 inhibitor, once started, you can continue. Even if you reach end stage, you can continue. The only point, not just hyperkalemia, the only point where you're going to withdraw this drug is changing GFR. If you have a patient who is landing up on acute and chronic kidney disease, where GFR is falling bit more than 20% within a span of 2 weeks, in such patient you have to take them off. You can reintroduce it later in a stable GFR state, but you cannot use it in a rough C. You cannot use it in a dynamic GFR. So that is the point which is more important, when you should know when to withdraw ACE-ARB than to know when to use ACE-ARB.
Any other question? Then we should call it a day. Thank you, Dr.
Gurudev.
Kumar.
Thank you so much, speaker. Thank you, our chairperson. This is like three musketeers of Howrah Diabetic Society together on the stage. Thank you, sir. Okay.